Hello everyone, how are you? I hope that you are doing amazing. It is Dr. Splichal, functional podiatrist, human movement specialist, educator about barefoot science, and founder of Naboso. Today, we are speaking about bunions, one of the favorite topics of many, but our spin on bunions is going to be when to have surgery, to actually have surgery, and to understand how to rehab after surgery. So I did a post, or I shared a post with some x-rays, and I just want to build this foundation of really what's going on with a bunion and why is there an advantage. So I know that we think of Dr. Emily, very functional. I actually put down my scalpel. I don't do surgery anymore, but there is a appropriate time and indication that I do actually suggest bunion surgery. Now, before you kind of step away and freak out that I'm saying that, I want to first go in about one of the most important things that we're going over when we speak about the bunion is the health of our great toe joint, that first MPJ. So as our bunion starts to become larger and the big toe deviates off of that first metatarsal head, you are starting to lose centration of the first MPJ. I'm going to show you what that looks like. So when we look at this x-ray, this is an x-ray of a bunion. You can see the clear deviation of that first metatarsal. We see this prominent first metatarsal head, that bump, which is the first met head. And that's oftentimes what people think about with the bunion. And then we have this deviation of the hallux out towards the lesser digits. Now that deviation of the hallux, look what it's doing to that joint. Do you see how the great toe is no longer aligned with the cartilage of the first metatarsal head? So we have this angulation. When you lose centration of a joint, and you deviate off of that cartilage, you start to set yourself up for degenerative joint disease and arthritic changes to the joint. This is what we're trying to prevent as that bunion progresses. So the greater that you deviate or you lose centration of the first MPJ, you know that that client is at risk of forming arthritis. So when we look at a x-ray, or when I evaluate a bunion according to an x-ray, a bunion should not be evaluated just clinically based off of the size of the bump or the deviation of the great toe. You always want to look at x-ray or have a radiological kind of coupling or evaluation at the same time. And those x-rays are really important to see the size of the bunion and then the health of that first MPJ. So when we look at this patient, and that deviation off of that, I'm looking at what's happening from that joint. But before we get to that, I'm going to show you a healthy joint. So a healthy joint is going to be, I'm just going to show you that real quick. A healthy joint, if we look at it here, so we can see here, so one, we see good alignment. My apologies. The base of the proximal phalanx is in alignment with the head of the first metatarsal. So you have a cartilaginous surface here and a cartilaginous surface here, and they're in good alignment. This is a centrated joint. The next thing that you're looking at is the space. So do you see the space that is in between these two bones? You want to have a nice, healthy joint space, which is telling you about the degree of cushioning or the cartilage and hyaluronic acid that is sitting in that joint surface. So this would be a seemingly healthy joint as far as the joint surfaces. Now, when we look at a bunion that has progressed, we can see here, this will be this image again, okay? So we're looking at this x-ray. Let's say this patient has pain in their joint. Every time they take a step, they have pain in that first MPJ. So we take an x-ray and we look, okay? We see this, one of the cartilaginous surfaces here, and then the base of the hallux, that cartilage surface is here. So they no longer have joint alignment. This is going to say, no wonder you have pain. And then the next thing that we look for is the joint space. So we can see that this is really bone on bone. I don't see a lot of joint space for this patient or this individual. So they have degenerative joint disease in that first MPJ. Now, where this is important to understand is that not everyone who has a large bunion has the same degree of arthritis or degenerative joint disease. So where I'm trying to catch that patient and tell them this is the best time to do bunion surgery would be when there's this sweet spot of starting to present with pain, right? So symptomatic. They have a large enough bunion that indicates surgery. And then I know that there's enough joint cartilage and joint health to then allow a successful bunion surgery. So when we look at bunion surgeries, there's two main types of bunion surgery. One is going to be where you will essentially either do a correction at the base, which is known as a lapidus. It's a fusion of the metacuneiform joint. You'll still shave the bump and swing the head over through the correction here, or you'll do a distal procedure at the head of the metatarsal. Now, as you do that, as you straighten the toe, you start to open up the joint. Now, when you open up the joint, sorry, this fell asleep. When you open up the joint as part of that correction, you've just brought range of motion back into that joint. Now, the indication for that is someone who has a bunion, maybe has pain, but still has a healthy joint, still has healthy cartilage. I would say do that surgery. That's the first type. Second type of surgery is in someone just like this patient, where you are looking and you say, yes, you have a bunion, so it's indicated to do bunion surgery. You have pain, okay, great. But now what's our procedure? Can I open up that joint by doing a surgery here or a surgery here? Can I open up that joint? What happens if you bring range of motion to a joint that has no cartilage? What are you going to do for that patient? You are going to dramatically increase their pain, because you don't want to move joints bone on bone, no cartilage. That's extremely painful for the patients and the individuals, which means I can't do those first procedures that I had said. I have really limited procedures. I have either a joint implant, and a lot of surgeons will actually not do a joint implant or a joint replacement. So you'll replace the base of the proximal phalanx or the head of the first metatarsal. Some people will do both, okay? But you're doing a joint replacement. The only other option is going to be a joint fusion. So if you wait too long to do the bunion surgery and you wore down that joint completely and the arthritis is too progressed, you may have no choice but to fuse that joint. Now, where a joint fusion is not a good option from a functional perspective is you will have no range of motion of your first MPJ. So let's go back to walking and functional movement. If I fuse the first MPJ on someone who has a severe bunion with advanced arthritis, because that's my only option, right? Now, every time they take a step, they cannot get any dorsiflexion. So they become in this shortened stride. They turn their foot out and they compensate by doing a abducted gait. They start to lift their foot early off of the ground because they don't have that range of motion. They start to lose hip extension because, again, they don't have first MPJ dorsiflexion, and they start to shut off the glutes because of the change in the compensations in their gait. So this is why I never want a patient to wait too long or to miss this window of opportunity of doing a bunion correction when I can salvage that joint. I can protect that joint. And that would be those earlier procedures that I spoke about. So there's a sweet spot and a timing of the appropriateness of surgery. Now, not every bunion has a bump. So I just want to show, this was actually one of my patients. The other side And this can show you how quite advanced the arthritic changes can become. Do you see this foot? Okay. So this here, she does have a mild, you can see a mild bunion here, but look at that degree of arthritis. Look at all of this osteoblastic activity that is happening in this first MPJ, right? This joint, I'm sorry, you are going to have to fuse this little bad boy here, because even trying to salvage this joint, you're going to have to cut so much bone away that you would get a shortening of the joint. And when you do implants in the first MPJ, sometimes they don't take and they slide, and then you have to take them out and you fuse the joint. So my whole goal about speaking about bunions today is that there is a time and place for that bunion surgery, but that determination of the time and place for the bunion surgery as a recommendation is based off of the radiographic findings, the x-ray findings, and the interpretation or the analysis of their arthritis. If it is too advanced, or it's moving in the direction that it is going to be advanced, let's say 5 years from now, it's going to look like one of these x-rays, I want that patient to have that surgery now versus then when it's too late. Okay? And that's what I'm hoping that makes sense here. Now, what happens if you say, well, no, Dr. Emily, wait. What if I do foot corrective exercises now before it progresses? Can I actually stop it from progressing? The answer to that is maybe. It depends, right? It depends on what is the driving force behind that bunion. In many large bunions, such as what is indicated here, this is a large bunion. And I'm saying that not just on like, whoa, look at the size of the bump. I'm looking at it based off of this intermetatarsal angle. That angle tells me the grade or the size or the severity of that bunion. So the more severe the bunion, it's typically associated with a hypermobility or a ligament laxity of the foot. Those are harder to control and try to prevent from being advanced arthritic changes that eventually have to be fused, okay? But definitely do it. Try it. Go into the foot strengthening and use toe spacers and do short foot and strengthen your intrinsics. But if you do have a large bunion, it is in your best interest or the patient's best interest to follow the progression of that bunion based off of radiographic findings versus just, is my bump getting bigger? I'm concerned about the joint versus the bump size, okay? I'm not concerned about the aesthetics of them and their ability to find shoes or not find shoes. My goal through this explanation and when I speak to patients is I need to ensure that I'm tracking your joint health, the joint health, okay? Now, let's say that you have surgery. So your patient or your client had surgery. The way that you want to rehab that foot is going to be very similar to the way that you would prevent the bunion in the first place. Get their intrinsics strong, get them into sensory stimulation, maintain optimal range of motion of the foot and the ankle structures. Keep your feet connected to your core. Make sure your breath, pelvic floor, and foot are connected. So those same philosophies of what you do to prevent the bunions or to slow the progression of the bunion is what you do status post bunion surgery. Last thing that I want to speak about before I see if there's any questions is going to be, what if your patient had a fusion? So they didn't have the first type of bunion surgery that maintained the range of motion and brought them more range of motion, but they had the other type of surgery, which is the fusion. What do? That joint is fused. It's not going to move. Okay, so if you try to bring movement, where a lot of people bring movement when they have a fusion of the first MPJ is they actually go to that joint. Computer went to sleep. They go to this joint, to the IPJ. And you never want to try to replace the MPJ with your IPJ. That's not what that joint is intended for. Your IPJs, especially your distal IPJ here, does not need to have a lot of range of motion. Don't try to have your toe contracting like this. That can really create a lot of arthritic changes and symptoms in the IPJ, right? Think of your digits as long, straight, flat to the ground, and then they're anchored. So they're anchored through the pads of the digits versus this, right? As soon as you keep doing that, especially again into that IPJ of the hallux, you're going to have symptoms. What you want to do then is look at how can I optimize someone's gait after they have a fusion. You're really going to have to look at shoes. So using a rocker-based shoe, such as a Hoka, Reshod, Danskos, you can actually get a 4-foot rocker added to shoes. I will write a prescription and tell the patient to take it to a shoe cobbler, and they can take off the sole of the shoe, put a graphite rocker, put the sole back on the shoe, and there you go. You have a rocker. So that's what we want to think about when it deals with different types of bunion surgery. One that optimizes range of motion, which versus one that fuses that range of motion. And then where is that sweet spot to then help them know the best time to have that surgery? Okay, I want to see if there's any questions. Type in if you have questions related to this. And again, some of you may be like, oh my God, I cannot believe she recommended surgery. Again, my job and really your job should be to protect, not just thinking bigger picture function and don't have the surgery because I hear of a poor success rate around it, but is to protect that joint, the centration of that joint. So let's see if there are any questions. Again, type those in if you have them. I see so many great faces on here, names. Perfect. Just a little zip through here. Okay, is it possible to help correct bunions through strengthening the big toe muscle and other intrinsic muscles of the foot? So absolutely, I just said that, Jake. But again, you would want to monitor the foot and see how that joint health is progressing. I typically tell patients that have moderate to severe bunions, think of it like, you go to the dentist, you have this annual checkup. You can absolutely get an x-ray once a year and you monitor and you track your joint health. And when I do tell patients that they really should have surgery, I'm typically saying, in the next couple years, you may want to have surgery because of the way that your joint is demonstrating right now. There are some that are a little bit more urgent, and I will say, I would probably do this in the next 6 months because of the degree or the severity of the arthritis. But again, just monitor it and think about that joint health. Perfect. If the bunion is not painful, are intrinsic foot exercises best to prevent the future surgery? Absolutely. Short foot away, correct toe away, foot to core away, and maintain that ankle mobility. Perfect. Great. Someone just had a bunion chip removed that was in the IPJ to avoid a bunion, and this was so helpful. Excellent. That's so good. I'm glad, Yogi Jules. Perfect. Great. So if there are no more questions, then I hope that you enjoyed the benefit of understanding the bunion and the appropriateness of bunion surgery. Stay tuned for more IG Lives about various foot conditions. And if you have any requests that you want to learn a little bit more about these different foot conditions and what is Dr. Emily's perspective, just please inbox me and we'll schedule that for one of these upcoming IG Lives. Thank you guys so much. Have an awesome weekend.